Hey, it's your old pal, Dr. Steve, and welcome to the SARS-CoV-2 COVID-19 updated simulation report for April 12, 2020. This is the fourth in a weekly series, and previous episodes are available and have general information about the current pandemic that are not covered on a weekly basis. Okay, let's get started with the current statistics that we're following. Well, first thing you can see is that according to the WHO, and this is the data set that I started this database with, so I'm just going to stick with it. In the United States, there are about 461,275 known cases of COVID-19. And if we use the Diamond Princess data that showed about 46% of people who tested positive for the disease were asymptomatic, that would make you think there's about 900,000 people who actually have it, which gives us the known cases, 0.14% of the population, total possible cases, 0.28%, and the asymptomatic population may even be greater than that. We don't know. We're going to know soon now that we're finally doing a lot more testing, so we should get a much better estimate of the asymptomatic rate. This is compared to China's 0.006% of their population and Italy's 0.24% of their population. So on a graphical representation, this is about when states started mandating social distancing, or at least strongly recommending it. And you can see that we have this sort of linear stretch right here where, this curve could have gone this way. And now it's a little more linear. China had flattened significantly, but now it's starting to increase again, maybe starting to flatten again right here. We'll see. It's impossible to know which way this is going to go. Italy is showing a bit of an S-curve. It's a very subtle one, but there's an S-curve there. So I'm hoping over the next couple of weeks we'll start to see this flattening out. I'd sure like to see that in the United States as well. Here's the epidemic curve from last week, and here it is this week. You can see Europe certainly has leveled off in cases. And the Americas, it's hard to tell from this. It's a little choppy. The Western Pacific continues to have this smoldering of cases way down on the curve here. So I was a day trader for a while, and one of the things that we would look at were simple moving averages, and then there are other kinds too, exponential moving averages and other things like that. But the simple moving average is just simply a 5-day average. So you go back 5 days, and here's the average over the last 5 days and the average over the next 5 days. And I did 5 and 20. I picked 5 because, these are kind of arbitrary, but I picked 5 because 5 days is the average amount of time it takes for someone to develop symptoms once they are exposed. And 20 days is the average amount of time that people are sick once they've been exposed. So you get sick on day 5 to 11, then you're sick for another 10 to 14 days. Okay, so it's somewhere in there. And what we're looking for, and the reason that I did this is because this is looking more and more like a stock chart to me. And I thought, why not apply some statistical analysis to this to see when we're at the peak and we're going to start falling off the other side of this peak. And right here is the first time. This doesn't count. This is a bad data point here. So this should have gone this way. Okay. So this is the first time since way back here that the curve crossed over the 5-day moving average. It's not come close to crossing over the 20-day moving average yet. But this is the beginning of maybe what we would call in stock market a beginning of a sell signal. That this stock may be slowing down. This double hump here and here is also often seen right before something begins to crash or decrease. And what I'm really looking for, though, is this 5-day moving average crossing below the 20-day moving average. And that's a very strong signal that we are in a decline at that point. And in stock market parlance, it's a strong sell signal. Here's where we were last week, and here's where we are this week. If you're interested in where those two show up to each other, this section here is where we were last week. You can also notice that 5-day smooth, simple moving average is actually looking like it's leveling off. So these are so-called, preemptive indicators. In other words, they can't predict the future. They can only tell you where you've been, but sometimes where we've been will inform us as to where we're going. There's another technical analysis tool that I always like to use, and these are these Bollinger Bands. And this is a technical analysis tool that's used in stock trading, and you create these envelopes, and they're plotted at a standard deviation, 2 times the standard deviation above and below the simple moving average. And I'll show you. It'll make sense when you see it. These things will decrease when there's low volatility. That makes sense, right? When there's low standard deviation, there's little change in the data. If you get the same price day in and day out, or the same number of new cases day in and day out, you'll see those bands start to narrow. And the numbers may hug one band or the other during a strong trend. So on the way up, they'll tend to hug the top band, and on the way down, they'll tend to hug the bottom band. But they'll bounce around inside this tube made by these Bollinger Bands. Now, viruses obviously aren't stocks, but it may help enhance our visualization of the numbers. I don't know. So here are the Bollinger Bands. Here's the top band. Here's the bottom band. The blue is the simple moving average for 20 days, and this is the actual number of new cases plotted inside on the same scale. And you can see, as this thing was going up, just as I predicted, and really the math predicts it, that this price chart was hugging this upper band. But right about day 77, it started to separate from that upper band. Even though you can't see a whole lot of change here, this is pretty sensitive, and you can see it separating from the upper band. And you can also see that the upper and lower bands are starting to once again start to converge. So that's what we're looking for. We'd like to see them converge, and then this thing start to hug the bottom band as they go back down. So I'll watch that over time. We'll see if anything interesting comes out of it. Comparing to influenza again, the CDC estimates about, 45 million influenza illnesses in the United States this year, compared to 461,000 COVID-19 cases. Now, this is comparing apples to oranges. This is not the number of laboratory confirmed influenza illnesses. They are inferring that given historical data. By the number of positive tests that they've had. So this is the number of people that we've confirmed have it. This is how much they've estimated. So that's not that useful. This is the number of hospitalizations. However, given 12.3 hospitalizations per 100,000, which is the way that the CDC is quoting these right now and not giving us the actual number. You have to do the math for yourself compared to, probably 500,000 influenza hospitalizations. And influenza deaths, anywhere between 24 and 62,000. We're starting to bump up against the bottom end of that with COVID deaths at 16,596. Okay, finally you get to see what's behind this slide. I kept clicking on it by accident. The United States is testing a whole lot of people, 2.6 million tests in the United States. And that looks like a lot. Italy's way down here, and then here's, I don't know who that is. Who is that? South Korea. But we got to look at per capita numbers. Absolute numbers don't tell the whole story. So in per capita numbers, you can see that the United States is doing about 8 right now, has done 8 tests per 1,000 people. And Italy, for counterexample, has done 16 tests per 1,000 people. So I expect this number to skyrocket over the next 2 weeks, and see a lot more tests being done as they're just starting to flood the market. Now, I've seen a lot of controversy about classifying COVID-19 deaths. People have tweeted to me saying that they're worried that some of the medical examiners or governors are writing COVID-19 on everyone, even if it's just peripheral, for some nefarious reason. I still haven't quite figured out what the nefarious reason is. Maybe to get more resources out of the federal government, whatever it is. The WHO has developed the following definition for reporting COVID deaths. A COVID-19 death is defined for surveillance purposes as a death resulting from a clinically compatible illness. So this could be respiratory failure. The way I would code someone who died of respiratory failure on their death certificate would be respiratory failure as a consequence of viral pneumonia as a consequence of SARS-CoV-2, parentheses, COVID-19. Okay? So that makes sense. That should be counted as a COVID-19 death. What they're saying is if there's a clear alternative cause of death that can't be related to COVID disease, like a motor vehicle accident. Let's say someone was in a car wreck and they died, and when they did the autopsy, they just happened to do a COVID-19 test, or that maybe they had one that was pending. They were totally asymptomatic, came back positive. You would not list that as a COVID-19 death. That's not the correct way to do a death certificate. So people are concerned that they're overly inflating the death rate from this because of this kind of stuff. If it's more than 1% of the death certificates that are miscoded like that, I would be very surprised. But, I look forward to seeing that data as well. I'm just guessing, but, I do a lot of death certificates, and I would never in a million years call a motor vehicle accident related to COVID unless the person suffered respiratory failure on the way to the hospital and wrecked because of their COVID-19. Been a lot of media frenzy, and we're going to talk about absolute versus relative numbers. Here's the headlines. U.S. now has more coronavirus deaths than any other country. The worst of the epidemic may not be far off. Confirmed U.S. COVID-19 death toll reaches 20,000, highest in the world. The U.S. now has the most confirmed COVID-19 cases in the world, et cetera, et cetera. Okay, that's factually true. It's also a misuse of the numbers, in my opinion. So now these are Johns Hopkins numbers, so they're going to be a little bit different. So let's, as far as absolute numbers are concerned, that's absolutely right. 526,396 cases. That's about a third of all the cases in the world right now, and tops the list of all the other countries. Followed by Spain at 163 and Italy at 152. But if we look at it per capita, which is the way we really need to look at this, per capita, we rank 13th in number of cases. And I'm not even counting Guinea-Bissau and Kosovo, which are at the top here because my friend Daniel Stout's algorithm is reporting those incorrectly. But so we are 13th from the top, which is San Marino, which had very few cases, and Andorra has very few cases. But then you get down to Spain's got 163,000 cases, and they're at 348 cases per 100,000. We're at about 159 cases per 100,000. And this again speaks to that percentage of population that I showed you earlier. This is just another way to look at it. Now, if we look at deaths per 100,000, we're at number 12, ranked behind Spain, Andorra, Italy, Belgium, France, the UK, Switzerland, and even Sweden. Sweden having been touted as one of the models for not doing social distancing, or they are doing social distancing, but not locking down their economy. We might talk about that next week. Now, this is from covid.stoutlabs.com. This is my friend Daniel Stout's website, and he gets real-time data from Johns Hopkins and some other places. And this is total cases per 100,000 population. We're looking at two of the countries that are having a problem, that'd be USA and Italy, and two that are touted as doing very well, which are Singapore and Sweden. And the United States is here, and here is Italy. So Italy tops the list, and then the United States. Then we see Sweden and Singapore. Singapore has very few cases per 100,000 compared to, say, Italy or the United States. We look at deaths per 100,000, though. Italy is still at the top. Now, Sweden inches above the United States, so they have somewhat more deaths per 100,000 than the United States does, and then Singapore is way the heck down here. So we talked about Singapore last time. If you're interested in knowing what they're doing, please go check out the COVID SITREP that's immediately prior to this one. And they are doing an interesting model where they're keeping their schools open, and a lot of stores and restaurants are still open. But when they get a case, they do very vigorous contact tracing, just as if you had an STD and you report it to the health department, and then they call everybody that you had contact with in that way and treated them all to stop the spread of that disease. It's the same thing here. So if you went to the market and you saw this cashier, all those people get isolated. And they isolate for 14 days. If they don't get sick, they can come back out into society. If they do get sick, they didn't give it to anybody else. That may be a way and a good model for us to consider once we reopen our economy. It would be to look at Singapore. Okay, so let's go to our drug update. There's more controversy regarding hydroxychloroquine. There's an article from NPR that says COVID-19 patients were given an unproven drug in a Texas nursing home in disconcerting move. Okay, I get it. This physician at the medical director at the nursing home decided all these people have COVID-19 in this nursing home. I'm going to give them all hydroxychloroquine. So 56 patients were given hydroxychloroquine, and they've had one death. So I decided to go back to the long-term care facility in King County, Washington, which was late February, early March. There were 129 patients and staff and 23 deaths. Now, I have seen this pushed at me both ways. I see people send me this article saying, look at this. And I see people sending me this article and saying, look, only they had 23 deaths. This other one only had one. This is extremely weak evidence. I know it looks good, but it's very weak. Here's why. They're comparing non-matched cohorts. Okay, we don't know what risk factors there were in each population. It's a very mixed population. In the one nursing facility, only patients got it. In the other one, patient staff and some other people got it. It's non-controlled. It's not a trial. There's no formal structure. And the Texas data has not fully matured yet. Yeah, there's only been one death. Let's wait 2-3 weeks and see. It's still very interesting, however. And there's a signal in there. Now, whether it's telling us something real or not, we won't know. We've got controlled trials coming. We've had a couple. One controlled trial showed it was ineffective, but they kind of waited until people were at death's door before they gave it to them. I don't think that's the right time to give it. I really think that the data so far, such as it is that we've gotten, is that early treatment in mild disease tends to prevent late severe disease. That's what will be interesting, because if that's true, we don't have to wait till people get sick and end up in the hospital. We can prevent them from going to the hospital. And that's what I'm hoping we'll see. No idea whether that's going to be the case, but I want to see a controlled trial with a lot of people where they're giving this to people early in the course of the disease, see if it keeps them from going to the hospital. If it does, we might be able to all go back to work, okay? The cardiovascular risks of hydroxychloroquine, I keep hearing about this. They are overblown at best, in my opinion. There's a 2018 Danish study of 3,742 rheumatoid arthritis patients on hydroxychloroquine. And interestingly, there was a significant reduction in cardiovascular-related death. And I'm quoting them, "We did not find any association between hydroxychloroquine use and the development of specific ischemic events, i.e. myocardial infarction, aka heart attack, and ischemic stroke, aka stroke. Okay? It's a pretty strong statement. Now, if you give hydroxychloroquine and azithromycin together, you may increase this thing called the QT interval. And I talked about that in the SITREP from 329.20. I went into it in detail about prolonged QT and torsade de pointes, which is the crazy rhythm that we're trying to avoid. Now, so feel free to go back and look at that. Didier Raoult has a new abstract out, not a published study yet, but a new abstract that presented 1,061 patients that were treated for at least 3 days with hydroxychloroquine and azithromycin and followed them up for at least 9 days. And he said, well, 98% of patients were cured so far. I don't know what that means. If the mortality rate is 1%, and what happened to those 2%? If only 98% got better, I'm a little concerned about this. It's uninterpretable. You can't interpret this. But he did say that no cardiac toxicity was observed, which makes sense to me. That if we're going to treat people with a combination that could increase this QT interval, but we're treating them for 5 days, I'm less concerned about it. I'm not saying that there won't be any problems, but I'm much less concerned about it than if we were giving it to them for weeks and weeks and weeks. He did say that mortality figures were improved in these patients compared with others receiving standard of care without such treatment. Now, I don't know what improved means. Better, I get it, but I would like to see the number. And so he's using historical controls, and there's no control cohort. So I don't know how he was monitoring cardiac toxicity. Did they do EKGs before and after? What were they do? Did they do continuous telemetry? I don't know. And so we really need to see definitive data, in my opinion, on early treatment of hydroxychloroquine regarding reduction in hospitalizations, reduction in deaths, and reduction in respiratory failure. If we can see that, we're going to be in pretty good shape with this. So with this drug particularly. Now, the other drug that's very interesting is remdesivir. This Gilead Labs developed it for Ebola, but it wasn't effective for that. But there was some positive effect in vitro and in animal studies in MERS. And in vitro means in the test tube. And the New England Journal of Medicine published a paper looking at early data on compassionate use of remdesivir. Now, these are people who were basically near death's door, and they said, okay, last-ditch effort, let's give them remdesivir. So there were 53 severe cases. Were given 68% of them improved. Again, uninterpretable. So if they hadn't gotten it, how many would have improved? That's what's interesting. So we have to compare it to standard treatment at some point, and we need to have a matched cohort. In other words, if we're not going to do a placebo-controlled trial, which I understand Didier Raoult argues it's not ethical for him to do placebo control because he believes that it's effective. That makes sense. If you believe something's going to save someone's life, giving them some other person a placebo and they possibly die would be unethical for you. It may not be unethical for other people who don't have that bias. But large-scale trials are underway on this remdesivir. It's in phase 3 testing. They're testing thousands of people. We should have an answer very soon. And the crazy thing is, let's just say that this drug is the drug that saves the world. It's going to be like $9 a dose. Gilead Labs is nuts. Bless them for not jacking up the price of this drug. But that's what's being reported to me. It's going to be about $9 a dose, which is incredible. Heck, I think we could. If we can afford $2 trillion with this bailout, we could just about afford to buy everybody their remdesivir. So, things that are happening this week. There will be data, and more data coming out. I will report to you anything interesting that I find. The antibody test kits are finally here. In your community, they may exist. They exist in our community, and I've seen other communities that are using them. These are really important for determining what the asymptomatic population is, and for determining who is safe to go back to work. With the one caveat, just because you have a positive IgG, which is the antibody that shows up after that's sort of the body's immune memory. After you've resolved the infection, you develop these IgG antibodies. Then you if you show positive for IgG antibodies, it's possible that these tests could be cross-reacting with other coronaviruses. So we need to nail down what that number is so that you can say, well, you've only got a 2% chance of being not immune to this. But I would not take a positive IgG to mean that you are absolutely invulnerable to this disease. You may be, but I wouldn't take that. Now, if you had a positive polymerase chain reaction, positive COVID-19 test, and you didn't develop IgG antibodies, now that is a person that likely cannot be reinfected and can go back to work and be on the front lines and not worry about it. So we'll see. We'll get some guidance on this very soon, I think. Stay healthy, isolate, wash your hands. Soap is always better than gel. Wear a cloth covering over your face when social distancing is difficult, like the grocery store or a pharmacy. It's not absolute protection. It protects other people from you giving it to them if you're asymptomatic carrier. But so we need to continue to practice social distancing until we get a valid treatment or the vaccine. Check out my Twitter at Weird Medicine, our podcast at riotcast.com/weirdmedicine. Listen to our show on SiriusXM on Faction Talk 103 Sunday nights at 5 p.m., Saturdays at 8 p.m., and on demand. And until then, stay healthy.